Again, good evening. My name is Tim Gibbs, Director of Delaware Health Force and member of the Delaware Academy of Medicine, Delaware Public Health Association. I'm joined this evening by my colleague from the Sussex County Health Coalition, Christy Handley, and by our guest speaker, Craig Laing. So, Delaware Mini Medical School South, early fall 2024. There will be a session starting 2 weeks after this one ends. So if you like this one, join us for the next one. And let me get my mouse in the right place so I can actually move forward in the slides. So here are our social media links. LinkedIn, Facebook, Instagram, X, and then for the Sussex County Health Coalition, Christina, I never asked, is that your Facebook account or your website?
Our website.
Oh, okay, all right. Anyway, and then there are the links down below. So about the program, we started this back in 2009. The Academy, by the way, has been around since 1930. This program is funded through the governor's office with American Rescue Plan Act funding. And before that, it was self-funded through the Academy DPHA funds and in partnership with various hospitals and other institutions, just like we're doing for the first time this evening with Bayhealth. This is a partnership between Delaware Health Force, the Sussex County Health Coalition, and Bayhealth. About attendance, you can attend as many of these sessions as you would like throughout the 6 weeks. If you are looking for a signed certificate, you must attend either 6 sessions live or 5 sessions live. And if you miss one, you can do a makeup. Let me tell you how the makeup works. You would send an email to me, tgibbs@delamed.org, and you would say, Tim, I missed the session. I would like to do a makeup. We'll send you the link. And then after you've watched the session, I will ask you a couple of relatively simple questions, and we'll be off and running, and that's your makeup session. There's no continuing medical education for attending this. This is primarily geared towards students of many ages who are interested in a career in the health sciences. Adults are certainly welcome to join us. Parents, if you're here with your kids, that's fantastic. There are no tests and grades except for if you miss a session, you're going to have to answer a couple of questions to prove that you actually watched the video. Why do we do this? We want to enhance health literacy for our communities. And what that means is we want you to understand more about how your body works, how we diagnose and we treat illness, how we do preventive care, and so on. As I said, we're exposing middle, junior, high school, undergrad students in a range of topics and types of providers as part of career goal setting. Mini medical school is not taught by all physicians. It's taught by a number of different disciplines because all the disciplines work together to form the field of healthcare that we call medicine. Our speakers are going to be sharing their career pathways. How did they get to where they are? And whether they're a clinician or a provider or a researcher, they'll share a little bit about their journey to where they are today. And we're also encouraging through the Q&A at the end, a dialogue between you and the presenters. This is a unique opportunity for you to speak with people where your own health is not at stake. You're not about to get a shot. You're not about to get bad news. This is an opportunity to talk with people who sometimes might be operating so far behind the scenes that you'd never get the opportunity to interact with them anyway. There are different levels here, and I encourage you all to go to delawareminimed.org to understand certificate levels and becoming a member of the Delaware Youth Medical Academy. I will send a separate email that goes into this in further depth because I appreciate that this can be a little bit confusing, this little matrix we have here. However, the Delaware Youth Medical Academy is limited to middle, junior, and high school students only. Right now, there are 39 members, and what you do to become a member of the Academy is you attend a full 6 sessions or 5 plus a 1 makeup, and then you write a paper. There we go on that. Housekeeping tips. This is a Zoom webinar. That's why you're not seeing each other. It's a webinar rather than a meeting. Please use the Q&A feature to ask your questions, and we will get to them as we can. Please do not ask questions of a personal or family nature. It's a violation of privacy rights, and we have to take that very seriously. All questions will be addressed, some by staff, others questions will be selected for direct answer by the presenter at the end of their presentation. You do need to stay through the entire presentation in order to be counted as here, but once the Q&A starts, you can leave. As I always say, often the Q&A is where the really cool stuff, the cool learning comes out though, and we recommend you stay if you can. This is the fall lineup. So we'll be ending on October the 16th and then starting 2 weeks later for the second fall session. And at this point, I'm going to turn it over to Christy Handley to introduce this evening's speaker.
Great. Thank you, Tim. I appreciate that. So like Tim said, I'm Christy Handley. I am from the Sussex County Health Coalition, which is located in Sussex County. And we are here to engage communities in collaborative, family-focused efforts to make sure that we're improving the life and well-being of others in our communities, children, youth, and families. So just wanted to kind of get that out of the way before I get to introduce Mr. Laing, our wonderful speaker tonight. So Craig Laing, is a nurse practitioner with 12 plus years in cardiology. He is currently working for Bayhealth, Sussex Cardiology practice. He is doing clinical work in cardiology. He is building an advanced practice clinician run heart failure clinic, and he is leading a care standardization process for all heart failure care at Bayhealth. Prior to joining Bayhealth, he was working for Christiana Care until November of 2023, where he was the lead nurse practitioner for advanced health or heart failure and mechanical circulatory support systems. He is an author. He is published in several peer-reviewed journals. He is a speaker, presenting at several lectures on various cardiology topics on both a local, regional, and national level. And his main interest is heart failure management, patients' outcomes, and program management. So I'm going to turn this over to Craig.
Hi, can everybody hear me? Good. All right. Good evening, everybody. Thank you for having me. As Christy said, my name is Craig Laing. I am the nurse practitioner for cardiology at Bayhealth Sussex. Previously at Christiana. I was at Christiana close to 21 years before coming down to Milford to work. The last 12 plus years prior to that doing cardiology as a nurse practitioner. So I know there are a lot of very interesting topics within the field of cardiology, and we're going to try and cover a vast majority of those tonight. Certainly with my background in heart failure, we could do an 8-hour lecture on heart failure alone, but I'm not going to subject you to that. So we will go ahead and get started with the presentation here.
Craig, your video went off and screen share isn't working yet. There you go.
All right. So tonight's topic, we're going to learn about understanding cardiology. So the goal of our objectives tonight is going to gain a basic understanding of the heart and what it does, gain a basic understanding of diseases of the heart, gain a basic understanding of how heart disease is treated, and then finally learning how to protect the heart from developing disease. One of our jobs, not only as clinicians in treating health problems that arise throughout a patient's life with medical therapy or interventions, but one of the primary things we look at doing is preventing disease. So, for those of you looking for careers in healthcare, that's certainly something that is important in understanding of how we can educate our patients and their family members on reducing risks for development of disease. So basically, what does the heart do? The heart is a muscle inside of your chest that pumps blood to every cell in your body. Your cells require blood containing oxygen to sustain life. And the heart also receives blood from the body after it's been used and coming back to the heart to go to the lungs to pick up fresh oxygen to complete the cycle. So understanding the anatomy of the heart or the actual structure of the heart, there are three layers that surround the heart. Our outermost layer is called the pericardium. It's a very, very thin layer of tissue. It contains a very small amount of fluid that helps the heart glide with each heartbeat, that it reduces friction and wear and tear on the actual muscle itself. The next layer is the myocardium, and this is the actual muscle layer of the heart. And so your heart, just like your biceps or your triceps or your quads, is a muscle. And it's through the movement of this muscle that allows contraction and squeezing of the heart to pump blood throughout your body. And then your endocardium is the innermost layer that lines the heart. And so if you were to cut the heart in half and take a look, and you would be able to see that inner lining of the endocardium. You would see the myocardium there, and then you would see the outer layer. The pericardium is almost like a sac that surrounds the heart. So your heart is divided into four chambers. You have your upper chambers and your lower chambers, and the upper chambers are called your atrium, and your bottom chambers are called the ventricles. And we have a left side and a right side to the heart. So our left atrium sits right above the left ventricle. Next to that is your right ventricle, and sitting on top of that is your right atrium. We also have blood vessels that are connected to our heart. And so the main blood vessels we have on the heart are our superior and inferior vena cava, which you can see there on the left side of the heart in blue. And that is a large vein that delivers all of the used blood from your body back to the heart, that it can go to the lungs and pick up fresh oxygen. So your superior vena cava is getting blood from your upper half of the body. Your inferior vena cava is getting all the blood from the lower half of your body. The other blue vessel you see there right in the middle, kind of at an angle, is called the pulmonary artery. And that leaves the right ventricle to take blood to the lungs to get rid of carbon dioxide and pick up fresh oxygen. Sitting in between the superior vena cava at the top there and that pulmonary artery in the middle, you see that red kind of curved blood vessel called the aorta. And this is the largest artery in our body, and this comes directly off the left ventricle of the heart. And every drop of blood that leaves your heart with every heartbeat travels through your aorta and then branches out to hundreds of other arteries through your body to deliver blood to those cells. And then finally, you can see there at around the 3 o'clock and the 9 o'clock position on the heart is your pulmonary veins, and they're labeled left pulmonary veins and right pulmonary veins. And the pulmonary veins are bringing fresh oxygenated blood from the lungs back to the heart to be delivered to the body with every heartbeat. Okay. Separating the four chambers of our heart, we have valves. And there are four valves in your heart: your aortic valve, your mitral valve, your pulmonic valve, and your tricuspid valve. The aortic valve separates the aorta from the left ventricle. The mitral valve separates the left atrium from the left ventricle. The pulmonary or pulmonic valve separates the right ventricle from the pulmonary artery. And your tricuspid valve separates the right atrium from the right ventricle. And the reason we have valves there is to help prevent blood from flowing in the wrong direction. You can see on the picture here where the down arrow from the left atrium to the left ventricle there on the right side of the heart, blood is traveling from that left atrium through the mitral valve to the left ventricle, and from the left ventricle goes up into the aorta. And so those valves open and close with every heartbeat that allows blood to move forward, but does not allow it to float back in the wrong direction. And we'll talk some more about problems that arise in our valves later on in the lecture here. Besides the valves that we see and the blood vessels that are delivering blood throughout the body, we also have our coronary arteries. And people tend to be a little bit more familiar with the coronary arteries because this is where we find coronary artery disease. So if you have heard of somebody who's had a heart attack, or they have had a procedure where they had to have a stent placed in their heart due to a blockage, that occurs in the coronary arteries, which sit on the outside surface of your heart. Our predominant coronary arteries are our right coronary artery, our right marginal artery that comes off of the right coronary artery. We have a left main or left coronary artery, and that comes off of the aorta and supplies the rest of the coronary arteries. We have a left anterior descending artery that supplies blood to the left ventricle, and your left ventricle is the real workhorse of your heart. That is the chamber that is pumping blood through the aortic valve and through the aorta to your body. And we have diagonal arteries that come off of that and a circumflex artery. And so when disease develops in these arteries, it affects blood flow to those sections of the heart and can make the heart not work adequately. It can affect the electrical system inside of your heart that causes a heart to beat and can potentially cause lethal heart rhythms. And so if you've ever seen a movie or a TV show where they put paddles on somebody's chest and they shock the heart, or if you're out in the community at your schools, you have these, at the library, at the mall, they have the AEDs, or automatic external defibrillators. Those are devices used to deliver an electric shock to the heart, typically when patients have had a blockage in one of these coronary arteries that causes a heart attack and causes the heart to stop beating. Right. So what does the heart look like, and how big is the heart? The average size heart is about the size of a human fist, and so you can see a heart here in physician's hand, and if you look at the very top of the picture, about where 12 o'clock would be, you see what looks like an elephant's trunk on there. That is the aorta that is coming off of the heart. You can see some squiggly lines that look like tree roots on the outside of the heart coming down towards 6 o'clock and 4 o'clock. Those are your coronary arteries. And so you can picture, if this is in your hand, how small those coronary arteries are, but can cause so much damage. And then internally is the four chambers, and there's tissue that separates those left and right side of the heart called your septum. You're unable to see that from the outside, but this is what the outside of a human heart looks like. So we look at blood flow through the heart. Uh, just waiting on this slide to load here. There we go. All right, so you can see the flow of blood through the heart chambers and those blood vessels that we were talking about. Okay. So we're moving forward here, talking about diseases of the heart. We talked about coronary artery disease as the buildup of plaques along the walls of those coronary arteries. Causes of these blockages include a high-fat diet. Uh, Fats have something called cholesterol, and cholesterol is something we need in our bodies. Our bodies naturally produce it. It's required for metabolism or breaking down of food. But when we have too much cholesterol in our body, it's kind of like if you pour hot grease down a kitchen pipe, and over time that'll build up and cause a blockage. We get these blockages in our coronary arteries from a high fat diet. Diabetes is another very big cause of blockages. And the reason is that these sugar crystals are microscopic, but they cause tearing inside of the blood vessel walls. And the body senses this damage to the wall and sends platelets to try and repair the damage that's been done. And it forms these clumps and clots inside the arteries there, which combined with these plaques from high cholesterol will form blockages, impairing the blood flow through the coronary arteries. And patients can have a heart attack or have chest pain because there's inadequate blood flow through the blood vessels of the coronary arteries. Smoking is a huge cause, maybe the number one cause of coronary artery disease. The toxic effects of cigarette smoke enter your blood vessels and cause damage to the lining of those artery walls. And much like with diabetes, when there's damage that occurs, the body tries to repair that and unfortunately ends up causing more problems. And then there's genes or your genetic, the DNA that was passed to you from your mother and your father. Uh, Unfortunately, some patients, despite eating extremely healthy, exercising, never smoking, being very fit, can still develop coronary artery disease just due to bad genes from their parents. So when we see what these plaques look like here, the blow up section here is of a coronary artery, and you see the red there labeled as blood clot. That's where there's been damage inside of your coronary arteries, and the platelets clump together to try and fix that. And then the yellow there is that plaque buildup, that cholesterol from a high fat diet. And unfortunately, piece of this plaque can break off and cause a complete blockage and cause a heart attack. And in cases like that, we will see changes on the electrocardiogram or EKG, which is an electrical measurement of the activity of the heart. And those patients undergo urgent procedure cardiac catheterization. Other types are like you see in the picture there, where there's a gradual narrowing due to plaque buildup, and patients can have a different type of heart attack from that, and they ultimately need to undergo cardiac catheterization, but the urgency is not there as when we see a piece of plaque that is broken off. How do we treat coronary artery disease? We'll wait for this video to load up here too. We'll have patients that come in with a various complaints of they have pain in their chest, they have shortness of breath, they get fatigued and tired with minimal to no activity. And so we will sometimes do what's called a stress test, where we make the heart exercise and see, is there impaired blood flow inside of the heart there. Sometimes we will take them to the cath lab without even doing a stress test because their symptoms are so bad. We may see changes on their EKG that are concerning. We may see blood work changes that are looking for damage to the heart that is concerning. And so we'll take them for a cardiac catheterization. And we go in for a cardiac catheterization through an artery. We can go in through your groin or through your wrist, and we guide a very small, flexible wire up to your heart under a special X-ray machine that gives us live images. Typically, you think of an X-ray like a chest X-ray as just a snapshot picture like you would take with your cell phone. But we have special X-ray machines that give live image, and so we can watch that catheter go up. And as you can see on the animation here, when we find blockages, we end up treating it with a balloon that pushes that blockage open, something called an angioplasty, and then place a stent, which is a metal cage that helps keep that artery open. So you can see the balloon being inflated there to open that blockage up, and the stent placed directly in the artery. And so that's how we treat blockages in our coronary arteries. And so that was obviously a computer animation. So I'll play you here a video. This is actual cardiac catheterization. You can see the picture on the left side of the screen there. There's a dark curve at the top. It kind of looks like an upside down J, and that is your right coronary artery. And you can see how it comes to an abrupt end at the very bottom, and that's due to a blockage. And you'll see as we open that up with a balloon and place a stent, how the dark flow will follow down the rest of that vessel, treating the blockage that is there. So these are the different images we look at on a catheterization, looking at all of the arteries, and you can see where that blockage is. And we will pass a wire through. You can see that come in faintly there, and we open that up with the balloon and the stent. There's the stent fully opened. And now we have complete blood flow. You can see the dark, that is the contrast that we give to allow us to see any blockages and then treatment of those blockages. So that's what we call a left heart catheterization. And that's how we treat coronary artery disease, in addition to medications that patients may take. So the next disease that we see in cardiology is heart failure, and this is actually the most prevalent disease in the United States. There are over 7 million people in the United States that have heart failure currently. Heart failure itself is the condition when the heart does not squeeze strong enough to pump blood forward, or the heart's very stiff and doesn't relax. And again, remember we discussed earlier, the heart is a muscle. And so we tend to think of when we lift weights and we make our biceps bigger, our arms are stronger. And in the case with the heart, sometimes when that heart has to work too hard, it becomes stiff and enlarged. And unlike our biceps working better, our heart does not work better. And what happens when the heart is stiff or doesn't squeeze well is that blood coming into the left ventricle can't fully be ejected with every heartbeat. And so it backs up, and it will back up through the left atrium, back up into your lungs, causing shortness of breath. Well, the right side of the heart still trying to pump blood to the lungs. And if the lungs are full, there's nowhere for that blood to go. And now that'll back up into your vena cava, the superior and inferior vena cava that we talked about earlier. And that will cause swelling in the belly, that will cause swelling in the legs. And ultimately, we can get dysfunction of other organs, such as our brain, our liver, and our kidneys. So when we look at heart failure, how we diagnose this is something called an echocardiogram. And it's simply an ultrasound that we do. If you've seen ultrasounds of babies when they're still in the uterus, is an ultrasound machine. It bounces sound waves off of the tissue and gives us a picture. Well, we do an ultrasound of the heart called an echocardiogram. And a normal echocardiogram we'll play here first on the left. You can see the 4 chambers of the heart. The top right chamber is your left ventricle. The top left chamber is the right ventricle. The bottom left chamber is your right atrium, and your bottom right chamber is your left atrium. So when we look at this, they're actually upside down and mirrored from what you think of normal spacing based on description. But if you look here, you can see all of those chambers. Again, the left ventricle on the top right there, squeezing nice and strong, um, pumping blood through the body. And we go to a patient that has heart failure. And again, we'll look that right upper chamber there that you see on the screen is the left ventricle. You see how that's significantly larger than the other one. That's where the heart's become enlarged over time due to the inability to empty. And the heart does not squeeze as strong. And so it causes blood to back up. It also decreases blood flow to your other organs. So we will typically see in patients that have heart failure issues with their kidneys. They develop kidney dysfunction. They also develop dysfunction in their brain where they have trouble remembering basic items. They have trouble with day-to-day management of living. So it's a very serious disease, and we, work really hard to treat this. So we look at what's called the ejection fraction. This is the percentage of blood that is pumped out of the heart with each heartbeat. And when we look at the images on the echocardiogram, we can determine what their ejection fraction is by what we see on there. A normal ejection fraction is around 50 to 70%. More likely 55 to 65% is what we go with clinically. Our borderline ejection fraction is 41 to 49%. And these are people who have had some damage to the heart. The heart's not working normally, but it still does pump blood. And then we have our reduced ejection fraction. These are our ejection fractions of less than 40%. And we saw that on that last echocardiogram. That echocardiogram, that patient's ejection fraction was around 20%. So it's working about a third as effective as a normal heart should. When we see these low ejection fractions here, we run the risk of what we call sudden cardiac death or a lethal heart rhythm. We spoke a few moments ago about the AEDs that we see out in the community and having to shock the hearts. So when patients have a reduced ejection fraction, we actually implant a defibrillator inside of their chest that monitors their heart rhythm. And if they go into a lethal heart rhythm, would shock them internally to bring them back to life. One of the things that we tend to not explain very well and we downplay in the community and even in healthcare itself is the severity of heart failure. The 5-year mortality rate, and mortality rate is the death rate. So, how many patients pass away from their disease from the time of diagnosis? Heart failure has a very, very high mortality rate at 50% at 5 years from diagnosis. We tend to think of this as a disease that we take pills and we may get some swelling and have to go into the hospital, but we don't really focus on the severity of it. And when we think of the word cancer and a cancer diagnosis, our first thought is, I'm going to die. I was diagnosed with cancer. And actually, our oncology colleagues do such a great job treating cancer. There's only a handful of cancers that have a higher 5-year mortality rate than heart failure does. And that's brain cancer, lung cancer, pancreatic cancer, and stomach cancer. All of the other cancers out there have a much better chance at survival after being diagnosed than being diagnosed with heart failure. So it's something we as a cardiology community need to increase the awareness of how severe heart failure really is and how serious we need to take treating heart failure. So the symptoms we see with heart failure, we have what we call right-sided heart failure or cor pulmonale. And there can be various causes of this. There can be an underlying lung disease that causes the right side of the heart to fail. Most common cause is the left side fails over time, causing the right side to fail. But we see fatigue. We see what's called ascites or fluid in the belly. You can develop where you look like you're 8 or 9 months pregnant, even as a man. And these are fluid collections. And we have to do a procedure called a thoracentesis, where we actually stick a needle into the abdominal cavity or your belly and drain fluid off. And we may take 10 to 15 liters of fluid off. So think about, 5 to, 6 2-liter bottles of soda we're draining out of somebody's belly. We get enlargement of the liver. We can cause permanent liver dysfunction. We get decreased appetite. Patients don't eat as well. They feel full when they eat a little bit of food. Their weight increases. They have swelling, especially in the legs. So those are our right-sided heart failure symptoms, and our left-sided heart failure is more related to what we see with the lungs. So we have paroxysmal nocturnal dyspnea, meaning at nighttime patients have increasing shortness of breath. They may have a cough, especially if they lay back flat because gravity's pushing that fluid up and stimulates your cough receptors. With a stethoscope, we can hear crackles in the lungs where every breath they take, that fluid is churning around inside the lung tissue. They may have wheezing because those airways are narrow. They may have tachypnea, which is a fancy medical word for breathing fast. They may have restlessness and confusion. Tachycardia is fast heart rate. The heart's trying to pump more blood, so it speeds up. They become exertional dyspnea or short of breath with activity. They're fatigued. They may have discoloration, cyanosis. Their lips and fingers and toes may turn blue because not enough oxygen is getting to the tissues there. So these are all signs and symptoms that we evaluate in patients with heart failure to determine, are they having a decompensation? They're filling with fluid. The heart is getting worse. And so when hearts do get worse, we have, limited treatment besides medical therapy. We have heart transplants where we take a heart from somebody who has passed away and we remove that heart and insert it into the person with heart failure. And we also have mechanical heart pumps, something called an LVAD. And you can see here the animation here. This is an LVAD, which is a surgically implanted pump that goes into the heart and essentially takes over the function of the heart to move blood. So you can see the LVAD there, that pump is spinning around 5,000 RPMs or revolutions per minute. So if you think about your car dashboard, you see the RPM gauge or the tachometer on your dashboard, and you press down the accelerator and your RPMs jump up to 3,000, 4,000 RPMs, and you hear that engine rev. Realize that little pump there sitting inside of the heart is spinning at 5,000 to 6,000 RPMs to draw that blood down and pump it throughout the body. So that was work I was doing in my previous role. Was we would implant these LVADs in patients with end-stage heart failure. Their heart was so bad. And this is actual video here from in the operating room when we were putting an LVAD in a patient. You can see that white cable up there is the outflow graft connecting the pump to the aorta where blood travels through to take over the normal function of the heart. So we move on to valvular disease here, and we have two types of valve disease. We have what's called stenosis, or the valve does not open properly, and we have regurgitation, where the valve may open and close but doesn't close properly. And if you remember, I spoke earlier about the valves. Their typical job is the gatekeeper between the chambers to keep blood from flowing the wrong direction. So when you have regurgitation and a valve doesn't close properly, blood will flow backwards where it shouldn't go and can cause issues with output of blood from the heart, with heart failure symptoms. So these are things that we need to evaluate and we treat sometimes with surgery. Typically, surgery has been what we call open heart surgery, where we put you under anesthesia and put you to sleep, and we make an incision in your chest and track your rib plate or your sternum and get down to the heart and open up the heart and put a new valve in. And that carries a lot of risks to do surgery in patients where we do open heart surgery, and not every patient is a candidate for open heart surgery. So we're now doing valve replacement through catheter. If you remember, we talked about the left heart catheterization. We go in through the groin and place a wire up to the heart to place a stent. Well, we can also go in through the veins and arteries and get up to the heart and put new valves in place. And so we look here at, a dysfunctional valve and how we can replace this. There was a great example there of what mitral regurgitation looks like, with blood going the wrong direction, and patients will get heart failure symptoms with that and can ultimately develop heart failure over time. Now we look at the aortic valve and a stenotic valve that doesn't open. So this means not enough blood can get out of the left ventricle and get to the body. And so patients can develop chest pain. They can develop heart failure, fatigue, because we're not getting appropriate levels of blood out of the heart. Could see that valve there, what was a normal functioning valve opening and closing, and then the stenotic valve kind of looked old and wrinkly and bubbly and doesn't work as well and does not allow blood to adequately leave the heart. So we're able to replace both the mitral valve and the aortic valve through catheters now. Through the groin, patients are out of the hospital within a day or two after this, whereas before we would have to do open heart surgery and they may be in the hospital for a week or two recovering from surgery. So we talked about fixing aortic valves through a catheter, and here's how we do this. It's called a transcatheter aortic valve replacement. So we guide a catheter up to the aortic valve, and we'll deploy the new valve right into its place there, take over those faulty leaflets that are your valves naturally, and now this artificial valve will function like a normal human heart valve would do and allow appropriate blood flow, whether forward or backward, through your heart. So that's how we're fixing valve problems, and doing this that we can get to more patients. We may have patients that are too frail, they have too many other medical issues to safely undergo open heart surgery. And prior to valve replacement with a catheter, there's nothing we could do for them to improve their symptoms or improve their quality of life, how they live. And oftentimes they would become bedbound where they couldn't get out of a bed or a chair and do activity. And we're now able to go in with a catheter, fix this, and they can go on and live many, many more years. So we look here at what causes heart failure. And we see a lot of causes. Obviously, number one is cigarette smoking. This is something that, over the last several decades, the healthcare community has worked extremely hard to reduce the number of people who are smoking, especially teenage smokers. Starting in your teens, it makes it even harder to quit as you get older. And so avoiding tobacco use completely is one of the number one ways that you can prevent the development of heart disease. And in all the years I've been doing this, so, I've had patients say, "Oh, I'm young. I'm not going to get heart problems. That happens to older people." I cannot tell you how many 30 and 40-year-olds I have had coming into the emergency room having a heart attack because they were smoking since they were teenagers. They were diabetic. They had poor diet. So all the things we think about as causes of heart disease, we tend to think this happens when you're in your 60s, 70s, 80s. And that's true. A lot of that does happen then, but we do see this happening in patients that are in their 30s and 40s when you're still relatively young, because they were doing these bad things like smoking and bad diet and lack of exercise. We talked earlier about the cholesterol, fried foods, fatty foods, high sugar foods. In moderation, you can have a little bit of those, but we want to be eating a low fat diet, high in protein, low in carbohydrates, to help prevent weight gain, which increases the workload of the heart. And when the heart has to work harder, it does not work as effective. We lead to obesity here, what we were just talking about. The more body you have for the heart to pump to, the less effective as it is. And a sedentary lifestyle, laying around on the sofa all the time, not exercising, um, certainly nowadays with 700 TV channels and video games to play and phones and all of that stuff, it's easy to become bogged down and not leave your room and get off electronics, and we're not getting the physical activity we need. You can have those things and still do those, but it's moderation and ensuring that you are getting appropriate physical activity every day, that we don't get this buildup of obesity with bad diet, with tobacco use leading to heart disease. And then we talked about our genes, our DNA, what we get from mom and dad. Okay. And high blood pressure. A lot of times, high blood pressure will go back to your diet and your weight. If you're obese and have a higher weight, um, it raises your blood pressure. So losing weight will actually lower your blood pressure. I just had a patient today, had sent a refill request in for a medication to treat her high blood pressure, and we've not seen her in the office for about 15 months now, a little over a year. And right before we had seen her previously, she underwent bariatric surgery for weight loss. And I told my office staff we need to bring her in for an urgent appointment because she's probably lost well over 100 pounds after surgery. And she may not need the same blood pressure medicine she did when she was obese. So, certainly, weight loss will improve your blood pressure and decrease the workload your heart has to do and help prevent heart disease. So how do we prevent heart disease? We talked about exercise and activity is very important. Every day, you should be looking at getting an hour's worth of physical activity at a bare minimum. It doesn't have to necessarily just be going to a gym. For a lot of my heart failure patients, going to a gym is impossible. It may be going to the grocery store and walking up and down the aisles, or go to the mall and walk up and down the hallways at the mall. For some of them, it's walking from the bedroom to the bathroom is the extent of the physical activity they're able to do. So we modify it for the individual patient, but we want everybody up and active as much as possible. Eating a healthy diet, low in fat, high in fruits and vegetables, limiting your carbohydrates. Carbohydrates are actually sugar, and can affect your blood sugar. And if you don't need that sugar immediately for activity, for fuel for your body, it actually gets stored as fat. So if you have heard of the Atkins diet or the keto diet, you eliminate carbohydrates from those diets to lose weight. And the reason being is now you don't have that carbohydrate fuel source coming in for energy, and your body needs energy. It burns fat for cellular energy. So it's not that you can't have carbohydrates, but a diet high in carbohydrates will increase your blood sugar and lead to weight gain. And then protein, and there's was just some information came out a couple of weeks ago in the national media, which is something in the heart failure world, we look at all the time, that you should be eating 1.0 to 1.2 grams per kilogram of protein per day. So if you take your body weight in kilograms, which is your weight in pounds divided by 2.2 to get your number of kilograms, and then multiply that by 1 is how many grams of protein you should be getting a day in a normal healthy diet. You're, especially as we age and we get up in our years a bit, we lose muscle mass and we get muscle wasting. And in order to generate new muscle, we need higher protein diets. So ensuring we're getting a balanced diet here with fruits, vegetables, good fats, carbohydrates, and protein. And again, not smoking. This is the number one thing you can do to prevent heart disease, is avoiding smoking. If you do smoke, is quitting as soon as possible. The sooner you quit, the faster your body starts regenerating those damaged cells and allowing your body a chance to heal. And then lowering your blood pressure. And a lot of times, it's a combination of all of these: quitting smoking, diet changes, weight loss, exercise that will lower your blood pressure and decrease the workload on your heart. Right. The medications we use for heart disease here, I tell patients all the time, we're not smart enough in cardiology to come up with a lot of fancy meds. We just recycle them for different conditions. But we have our beta blockers, and beta blockers end with LOL. So medications like metoprolol, carvedilol, bisoprolol, they block the release of stress hormones in our body that affect the heart. They also slow down the heart rate. So patients that may have fast heart rates and we want to lower that, we'll put them on this medication. We use it to lower blood pressure, and it decreases how hard the heart has to work. We have our ACE inhibitors. They all end with the IL, or PRIL, really: lisinopril, enalapril, captopril. These medications we use to treat high blood pressure. We use them in heart failure to block hormones that narrow blood vessels and hold on to salt. And salt is a magnet for water. So our patients with heart failure, we put them on a low sodium or low salt diet so they don't hold on to extra fluid. Our angiotensin receptor blockers are very much like ACE inhibitors, and they all end in the artin: losartan, valsartan, camisartan. We use these for blood pressure management. We use it for heart failure. We place patients on medication called statins. These work to lower your cholesterol. So you may have seen commercials on TV, or you're on these medications, or your family member may be on it. Medications like atorvastatin, simvastatin, and you may hear them by other names like Zocor, Crestor, or Lipitor. These are medicines to lower the cholesterol, which builds those plaques that we saw in the previous video with the catheterization. It's our simvastatin. That's a statin, is our cholesterol medications. Then we have our aspirin. This is hallmark of cardiology care for as long as cardiology has been around. This reduces the clotting ability of blood. And it used to be that when you turned 40 years old, they told you to take an aspirin a day to help prevent a heart attack or stroke. And that held true for decades. And back in about 10, 15 years ago, they actually came out and recommended, if you've never had cardiovascular disease, is to stop taking a baby aspirin as prevention, because the risk of having a bleed from your gastrointestinal system is higher. Again, because it affects your ability of clotting of blood. So if you have heart disease, we don't want clots forming in your coronary arteries, so we place you on aspirin. Then we have our diuretics. These are medications that work in the kidneys to help remove excess fluid. So typically we use these in our heart failure patients because the heart does not squeeze adequately to get blood to the kidneys to form urine to be able to urinate that out. they need extra help to pull the extra fluid out of their body. And so we give them diuretics, medications like Lasix or Bumex, work in the kidneys to increase the urine output. And so they end up peeing more. Then we have antiplatelet agents. So those patients that get a stent placed, those stents are at risk for clotting. So we'll put them on aspirin. We put them on other antiplatelet agents like Plavix, like Brilinta, that help keep the blood thin to prevent clots from forming around those stents. Then we have anticoagulants, and these were originally, we had warfarin or Coumadin is the other name for it. It's a blood thinner to help prevent clots from forming in the chambers of the heart or other areas in the body. You can get blood clots in your legs called a DVT or deep vein thrombosis can cause a pulmonary embolus or a blood clot in those pulmonary arteries we saw back in the anatomy of the heart. You can have a condition like atrial fibrillation, which is an abnormal beating of the heart, and a clot can form in the atria and travel to your brain and cause a stroke. It's the number one cause of strokes is atrial fibrillation. And so we put patients on blood thinners like Pradaxa or Xarelto or Eliquis or warfarin is the old one that we use. And so I know we're starting to run short on time here, so I wanted to open this up if there's questions or comments from the audience here.
Oh, there are questions. Hold on for just a second, please. All righty, very good. Just let me transcribe this one. Okay. We'll start with the most recent question. Why is aspirin suggested for pregnant women?
It should not be.
All right.
Unless you have underlying cardiovascular disease, you should not be taking aspirin.
Okay. Could or are beta blockers used like steroids in sports competitions?
So, yes, they are, and it's actually a performance enhancing agent in a lot of those that you have to get an exemption as an athlete to use that because it decreases the workload of the heart. The heart won't beat as fast. So theoretically, you can gain an advantage because your heart is not working as hard with physical activity.
Oh, okay. All righty. How many years after someone stops smoking would you see the best results possible in a patient's heart?
That's really patient specific, depending on how long they smoked, how much they smoked. But we do know within 30 minutes of their last cigarette, we start to see changes inside of the body as the effects of the nicotine wear off. The nicotine that's in tobacco smoke is a stimulant to the heart. It's a vasoconstrictor, so we will see narrowing of the blood vessels. When you smoke, we see an increase in the heart rate because of the stimulant effect. And so within half an hour, we start to see changes. In terms of long-term changes with the heart, it really goes back to, did you smoke for 2 years and it was a pack every 3 days versus were you, now I'm starting to date myself here back to, when you could smoke indoors and people smoke 3 and 4 packs a day because it was easy to do that when you were able to smoke indoors. And so if you were smoking 2 to 4 packs a day for 60 years, you're looking at 120 to a 240 year pack year history that we call it. We're not probably going to see a ton of cardiac improvement after 60 years of smoking that heavy.
I guess. Can heart failure also happen in an underweight person?
Can. And so if uh, for our younger audience here, ask your parents and maybe even your grandparents who the Carpenters were. They were a singing group, brother and sister, from the 1970s and early 80s. And Karen Carpenter was the lead singer and was a bulimic and ended up dying from heart failure because of her bulimia.
All righty. Hey, just reminding folks, ask your questions in the Q&A. We don't respond to raised hands. Sorry, Dylan. What is the percentage of the transcatheter valve that is somehow dislodging? And I'm reading that verbatim.
I don't have the actual percentage off the top of my head. I can tell you the incidence of it is extremely small.
Right. What machines do doctors use to detect valvular stenosis?
Uh, the most common is an echocardiogram, which is the ultrasound of the heart. We can also do MRIs of the heart and CAT scans of the heart, and be able to look at blood flow through those valves. When we get concerned about significant stenosis, our echocardiograms typically done on the chest. We squirt some warm gel on the chest and put the ultrasound probe on the chest, just like we would your belly. We can do also what's called a transesophageal echocardiogram, where we give you some sedation that you're asleep and not aware what's going on, and we insert an ultrasound probe down your throat and get a better look at the valves in the heart that way.
Thank you for that sedation.
Yes.
Hey, Craig, would you mind turning on your camera so we can see you while we're doing the Q&A? What machine? Oh, no, I asked that. Has an LVAD been put in for infants born with heart disease that would, or who would require a mechanical heart valve?
So a mechanical heart valve is actually contraindicated with the LVAD. You can do bioprosthetic or a pig valve or artificial valve. And was there a congenital component to that question?
Yeah, I think it was sort of a two-parter now that I read it. So are LVADs ever put into newborns?
Not newborn, simply because the pump is too large. Now you have temporary LVADs, things like ECMO or an Impella, that is a bedside LVAD and is a bridge to something, so to speak. We're trying to stabilize you or to get you to transplant. But in terms of a durable LVAD, like we saw the video, that you go home and live with that, you can do it in pediatrics, but you got to have a certain body size for that pump to actually be able to sit in. Typically in neonates, these are cardiac abnormalities are identified in utero. When the mother is getting an ultrasound, we actually do in utero cardiac surgery, where the baby is still in the uterus and they can go in and fix valve problems, or you can get malformations where they have one or two chambers instead of four chambers in the heart, and they get planned cardiac surgery as soon as they're born. But a lot of those where there's a significant problem, they're in early transplant. The problem with doing transplant is those hearts don't last forever. So if you're doing a heart transplant on a baby, they're going to need 2, 3, 4 more heart transplants to live to middle age. And you get to a certain point, they just stop opening up the chest because of all the scar tissue. So if we can do things in utero or other procedures that correct abnormalities without the transplant, that's the route to go first and save transplant for later.
Okay, so I'm going to ask this question verbatim. What happens if the LVAD blows up?
No, it won't blow up. It will clot off. Blood's flowing through there. Anybody with an LVAD is placed on warfarin as a blood thinner. And we've had patients, just in my experience, and this happens worldwide with LVADs, where a small clot can form. We had a guy come in once. His only complaint was that he said it felt like my belly was on fire. And we ended up doing a CAT scan and injected contrast through the CAT scan, and his entire LVAD was a clot from one end to the other, but the pump was still doing everything it could to churn it, and that was an older generation pump that spun at 10,000 RPMs. So that was literally why he was burning inside, was a pump was not moving blood but spinning that fast, and that was an emergent trip to the operating room and take the pump out and put a new one in.
Wow. Why does right side heart failure have a unique name, but left side failure doesn't?
Because the pulmonologist wanted to feel included when we talked about right side because it's related to the lungs, so they had to throw the pulmonale in there. In all honesty, you have something called pulmonary hypertension, which is high blood pressure inside those pulmonary arteries, and there's about 6 or 7 different subcategories of pulmonary hypertension. It can be caused by lung disease and have nothing to do with the left side of the heart. It can be caused by left-sided heart disease. It can be caused by viruses. So when you look at right-sided heart failure, you then have to determine what is the cause or the etiology behind that. So that's why we call it core pulmonale. It's a combination of core for cardiac and pulmonale for lung.
All right. How do doctors operate and place the stent into the heart without disturbing it?
It's always possible to disturb it. We're talking very, very small diameter vessels. If you think of a coffee stirrer, we're talking about the diameter of a coffee stirrer for your coronary arteries, and we're guiding a catheter wire through that and then placing these very small stents. So we use the x-ray you saw on the video of the catheterization, and we inject contrast or dye to be able to see where we're going. But there's always a risk that you poke a hole in the blood vessel. While you're doing that, you poke a hole in the heart, and those become surgical emergencies that we're going to the operating room and opening the chest typically, and then having to do bypass surgery.
All right. And speaking of contrast dyes, uh, what would be used if a patient is allergic to contrast dye?
It depends on what is the allergy. If it's severe anaphylaxis where the throat has swollen shut previously, um, we pre-medicate. If it's to get itching and hives, we still pre-medicate. So we'll give them steroids, we give them IV fluids, and in cases of severe reaction to previous contrast, we'll do 12 to 24 hours ahead of time with steroids, multiple doses, to decrease that response and kind of pray. So we have decisions to make as clinicians of risk versus benefit in terms of safety to move forward with that catheterization. And then we
Right.
limit the amount of contrast we give.
Right. And then is there a formula to help you calculate how much dye you need to see an artery based on body weight or?
No, it's really the dye is drawn up in a syringe pump, so to speak, and the interventional cardiologist will hit a button and it squirts dye in, and you automatically see it come up on the screen. And if your coronary arteries are what we call clean, or there's no blockages, we could be done a catheterization in 3 minutes. It takes longer to set up to do the prep for a catheterization than it does to do the actual catheterization. When we find disease and we have to place a stent, and sometimes we have trouble getting a wire, those plaques that we saw on there can become calcified and rock hard. And we don't want to chip away at it because a piece of that could break off and now cause a heart attack. And in cases like that, we have to use more contrast. And there's times quite often where we've had to give so much contrast that we'll stop the catheterization and say, we're going to bring you back in a week or two. We know where the blockage is now, and we can go in and do it then to limit the amount of contrast they get at once. Because contrast can be harmful to the kidneys and cause acute kidney failure.
Gotcha. What are the different risks for plaque to break off into our bloodstream and blood clots to form in overweight people compared to obese people?
So the definitions of overweight and obese are an academic definition that we've created in healthcare. There's something called your BMI or body mass index, and that's where we get overweight and obese and morbidly obese from. And as long as I've been doing this, I remember in my training arguing with one of my instructors that, BMI is not the end all be all. I said, if you take an NFL running back who is 5'9" with 4% body fat that weighs 250 pounds, by definition, he is morbidly obese. And their response is, you're never going to have an NFL running back as a patient. I said, but that's not the case. What causes it? We know as we age, our bones become brittle and they're less dense, and we develop osteoporosis. Whereas if you take that same patient at 22 years old that has thick, dense bones, that thick, dense bone is going to add to their weight. Same with muscle. We lose muscle as we get older. So there's a lot of things that go into overweight and obese. So that's one aspect of it. But then it's, where is the obesity? And we have what's called central obesity, which is across our abdominal region. You can develop something called metabolic syndrome, that we see this typical features of central obesity, high blood pressure, uh, decreased cortisol levels, high cholesterol panels. So we'll do what's called a lipid panel and look at their cholesterol numbers. So when you're obese, overweight, we tend to see higher numbers of that. But again, the body doesn't read the textbooks. I've seen patients that are on the verge of being, cachectic or, skin and bone and still have high cholesterol. But we know the obesity increases those risks.
Right. Okay. What got you interested in cardiology?
Uh, Make a long story short, I actually have a degree in music. Originally, I was going to be a high school band director, and my junior year of college, I had to write a paper on a field in music, and I picked music therapy. Found it really interesting, and got a part-time job at a rehab hospital where I was doing my undergrad degree. I needed, spending money, and uh, the healthcare team there kind of explained healthcare to me, and I found working there for a year and a half, like, this is really interesting, and graduated and said, let me try and do healthcare. Worst comes to worst, I'll spend a year taking classes again, and it doesn't work out, I can go back and teach. And 25 years later, here I am. I ended up getting a nursing degree. University of Delaware had just created a accelerated nursing program for second degree students. So I could get my nursing degree. And I knew I wanted to go on. I didn't want to just be an RN. I wanted to go to either physician assistant or nurse practitioner. The nurse practitioner route was better work-life balance. By then I had gotten married and had a kid and could do the NP route part-time. I was an ER nurse at Christiana while I was in graduate school for my nurse practitioner degree. I worked 11 at night to 11 in the morning, saw everything under the sun. I loved it. But seeing cardiology from that standpoint really was what made me want to go into cardiology.
All right. Is smoking more harmful to the heart or to the lungs, or is that an academic question?
A bit of both. And the reason I say that is, take my great grandmother, who started smoking when she was probably 13 or 14 years old and lived to be 100 and never had a single problem with her heart or lungs. I have seen 50-year-olds die of lung cancer that started smoking in their teens. I have seen 30-year-olds have heart attacks that started smoking in their teens. Part of it is patient specific. Either way, smoking's not good for either. It's not good for anything. I mean, it can cause cancer of the bladder, cancer of the stomach, besides the cardiac and the pulmonary issues. So there's not an equal distribution that we see, one way or the other between heart and lungs with smoking.
Right. So going back to the beginning, when you showed that the animation of blood flow through the heart, what happens to the flow when the heart skips a beat?
So the word skipping a beat is actually a misnomer. People think, when they say my heart skipped a beat, that it didn't beat. It's actually an extra beat that's thrown in there, something called a premature ventricular contraction or premature atrial contraction. Whether it's the top chamber, the atria, that throws in an extra beat, or the ventricle, the bottom chamber, that does. And so that blood is pumped out, but it's not with the same contractility or the same squeezing strength that a normal heartbeat would be. These PVCs and PACs are completely normal. Everybody has them. Most of the time, they don't even realize it. But some patients do feel what we call palpitations, or the heart skipping a beat. And, we'll order a heart monitor on them as an outpatient and see how frequent this is happening. And if we see it's with a high frequency and the patient's symptomatic, we can put them on medications like beta blockers to help suppress those extra beats.
Alrighty. Got a question for you. On your screen, do you see the Q&A button?
I don't.
All right, okay. I thought maybe we could make this easier for you.
Wait, here I do. Here we go.
So those are the questions that are in queue right now. And rather than me reading to them, if you would like to read them and then respond to them as they come to you, that would be great too. Your choice.
Yep. Yeah, I can go through here. So Anna asked about journey becoming an RN and an NP, barriers and challenges overcome along the way. I kind of talked a little bit about my background, being an ER nurse, while going to grad school to become an NP. I loved trauma also, and I was torn trauma or cardiology. And when I was graduating, trauma didn't have a job, cardiology did. So I went the cardiology route. Challenges with that, I was working 11 at night to 11:30 in the morning. I would come home, sleep for 3 hours, go to class from 4 to 7. I had a toddler and a newborn, and come back at 11 at night. So I didn't sleep much, and but that's part of healthcare. And when you're looking at training, and for those of you considering med school and going on, it's long hours like that. Your residency and fellowship training, you're in the hospital 24 hours plus at a time with minimal sleep. You give up things, but at the end of the day, I can tell you my background with heart failure, patients that couldn't get out of bed, that they go on to have surgery and we put an LVAD on them, or a heart transplant, and you see them now a year later and they're out boating or biking and know you're a part of that. That makes all those, lack of sleep nights and missing out on family events worth what you do. So how do doctors put stents in the heart? We go in through an artery, whether it's your femoral artery in the groin or your radial artery in the wrist, and we guide a catheter under that x-ray machine right up to where the blockage is. And that catheter wire has a stent embedded around it, and we inflate the balloon and the stent sticks. Some risk being on blood thinners. Biggest risk is bleeding. Your blood is thin being on blood thinners. So you cut yourself, you're going to bleed a bit more. Our biggest concern is patients that develop gastrointestinal bleeds. They get an ulcer in their stomach or a polyp in their colon, and that starts bleeding. And that can become a surgical emergency where we have to go in and stop the bleeding. So that's the biggest risk. Patients that are on blood thinners or antiplatelet agents, they bruise easier just because the blood is thinner. Coronary artery bypass. So coronary artery bypass is surgery. That's for blockages when we can't place a stent, or you may have so many blockages in various vessels that we actually take a vein typically out of your lower leg. We do open heart surgery, and we attach that vein to one end of the coronary artery and go around where the blockage is and attach it to the other end, and that becomes the new blood flow pattern around that blockage. Will your heart stop if you smoke for a very long time? Not from the smoking per se. I mean, the smoking itself will cause disease. It can cause your heart to stop. You have lung disease and you get severe emphysema or COPD, and you can't breathe, and you have buildup of carbon dioxide levels in your blood, can make you stop breathing, and then that would make your heart stop beating. But the smoking causing your heart to stop itself, the smoking will cause diseases that can cause your heart to stop. How can high school students apply to the Delaware Academy of Medicine? I think that's more for Tim and.
Yeah, and whoever is asking that question, if you could send an email to tgibbs@delamed.org, and I'll follow up with you directly.
All right. What is the education pathway of a cardiologist? How many years of college? So, anybody to get into medical school, you have to have 4 years of an undergraduate degree with your bachelor's degree. And then medical school is 4 years long after that. Once you finish medical school, you go into what's called residency, which is your training to become a doctor. To be a cardiologist, you have to do a residency in internal medicine, which is 3 years in length. And then to become a cardiologist, you then have to do another 3 years of cardiology fellowship, where it's training specifically in cardiology. And then if you want to specialize, if you want to be the doctor who puts stents in for somebody with coronary disease, is another year fellowship for interventional. If you want to do heart failure, is another year. If you want to do electrophysiology and put pacemakers and defibrillators, is another year. So you're looking at 4, 8, 11, 14, a minimum of 14 years after you graduate high school till you would be a cardiologist. But here's the thing I tell people, 14 years is going to happen whether you're in medical school to be a cardiologist or not. So if that's what your passion is and what your drive is, go for it, because those years are going to happen as it is. Can vaping also lead to heart disease? So there's still research coming out on this. What we're seeing is that there's lower incidence of vaping causing heart disease, realizing though that vaping and e-cigarette use was originally created for patients who smoke traditional cigarettes to wean off of those completely. And so the early data can be skewed because those patients do have a history of smoking tobacco. However, with the increase in teenage vaping over the last 5 to 6 years, that remains to be seen. Although I was just reading an article the other day, teenage vaping rates are lower than they were last year. So there is efforts being taken to help prevent that. We need more long-term studies to see if vaping itself, I mean, yes, it contains nicotine. Nicotine's a vasoconstrictor, causes those blood vessels to shrink down, causes the heart to work harder, but doesn't have the same toxic chemicals that traditional cigarette smoke does. Right. Aspirin was prescribed during pregnancy right after having COVID. Why was it prescribed? It could be because COVID can cause this prothrombotic state, and you're already prothrombotic when pregnant, meaning you're at an increased risk of blood clots developing. That helps prevent the blood clots from forming. And that may have been early in COVID too. We were doing more aspirin in people. I try and avoid the pregnancy stuff as much as possible. We used to get consults. You can actually develop heart failure from pregnancy itself, and those were the worst consults because you're dealing with 3 patients at that time. You're dealing with a pregnant mom, you're dealing with a fetus, and you're dealing with the scared father sitting in the corner. And a lot of the medications we use to treat heart failure are contraindicated, or we can't use in pregnancy because it can be harmful to the fetus. Could nicotine and smoking cause blood clots in the body? If so, how common is that? Yes, and there's actually a disease where we call it hamburger's disease or burger's disease, where you can need amputations, or where we have to cut off your feet or your hands because of smoking, where it's caused blood clots and the blood doesn't flow to your fingers and toes, and they die off and we have to amputate. So yes, it can. The concern actually, with women with oral contraceptives or birth control pills is over the age of 35. If you're on if you're a smoker, is to not prescribe birth control pills to women over the age of 35 because there's an increased risk of clot development and pulmonary embolus, or a blood clot in the lungs. If someone's afraid to go to the doctor for fear of getting bad news, what are some suggestions you would give to get this person to the doctor for a checkup? Uh, it's hard because you do want to be sensitive to patients' feeling, and there is apprehension to visiting healthcare. What I would say to those people is that, avoiding bad news, if it's really there, down the road, the news could be even worse. So while we may receive bad news in the immediate period, we have a lot of advancements in healthcare that, 10, 15, 20 years ago, those things that may have been lethal then, we're now able to treat. And so if we avoid that, things are only going to get worse, and we may lose our window of opportunity to provide treatment. Difference between heart attack and heart failure. So a heart attack is a blockage of your coronary arteries. It's impacting blood flow through those coronary arteries. It supplies blood to the heart. Heart failure is when the heart is not able to squeeze or relax and pump blood appropriately to your body. Most common common diagnostic test used to assess heart health. EKG is probably number one. We put electrodes on your chest, arms, and belly, and it gives us the electric picture of your heart, tells us what rhythm you're in. And I didn't even delve tonight into rhythms and EKGs. That's another 2-hour lecture there. Echocardiograms, the other big one. So between EKG and echocardiograms are the two most common to look at the heart, to evaluate the efficiency of the heart. How does a pacemaker affect the heart once put in? It depends on what we're putting the pacemaker in for. So a pacemaker will deliver a small electrical stimulation to make the heart beat at a certain number of beats per minute. It may be a backup where the patients had heart block, where there's a short in the electric system of the heart. Other times, we put it in heart failure where we'll actually put it in both sides, the left and the right ventricle, and take over the pacing of the heart at a set rate to increase the squeezing of the heart. The pacemaker, sometimes they're just as a backup and they're just sitting there doing nothing. Other patients, every heartbeat is paced because of that pacemaker. So it's kind of a patient specific and what the indication was for. Can excessive exercise also cause heart failure? Yes and no. It's when you see there's a test we do called a cardiopulmonary stress test. It's a lung test and a treadmill stress test for the heart. And if you're older, go back and watch Rocky IV, and if you remember Ivan Drago on the treadmill and he had the mask on, or the Gatorade commercial for the guys running on the treadmill with the face mask on, those are cardiopulmonary stress tests, and that's looking at heart lung function combined. And so we do these in heart failure all the time on patients to assess severity, but they do them in the hyper athletes, like these guys who are these ultra marathoners and do the Ironman competition out in Hawaii, and the function of their hearts is so off the chart that we can't even categorize it. Your typical athlete cannot generate that much metabolic equivalents to cause heart failure. At what age do cardiovascular issues arise the most, and how has the average age changed over time? So typically we start seeing most issues showing up in the 50s, age-wise, and that is because most people that start smoking in their teens, and they'll continue to smoke through their 40s. They may have quit by then, or in their 50s. A lot of people, you'll ask them when did they quit smoking, and it's the day they presented to the ER having their chest pain. So typically the 50s are what we see. Realize though that we're dealing with a generation before us and two generations before us where smoking was widely accepted. It was done in public. I remember as a kid, you could smoke on airplanes. You smoked in restaurants. You smoked in the mall. In the hospital, smoked. There were smoking lounges for the nurses and doctors. Uh, that all has changed. So we now have a new generation where the tobacco smoking prevalence is nowhere near what it was 40 years ago plus. So, we may see a shift in that age going later because not as many people are smoking as we used to see. Any recommendations for a high schooler who may be interested in pursuing cardiology in their future? Try and shadow as much as you can. Volunteer. The first thing to do is, not even so much focusing on cardiology, but can you volunteer at the hospital? I know that the hospitals have volunteers in the summer where teenagers can volunteer, and it just exposes you to healthcare. And if you know healthcare providers, say, can I come shadow you for a day and just see what you're doing? Look at all the different things out there. Attend events like this, stuff through the Delaware Academy of Medicine, and soak up and learn as much knowledge as you can. And be your own champion for learning. And read, as much as you can. Avoid going online and Googling things, and you're getting a million websites out there that have false information. If it comes from a healthcare system, comes from a respected medical journal, then you can believe it. But WebMD, stay away from, but try and find things that interest you, and shadow and volunteer is the best way to start. Which machine is usually used the least when it comes to medical problems relating to the heart? It varies because problems with the heart affect other organs. It'll affect your kidneys, your liver. So I mean, it depends on the individual patient if they have other conditions that may be affecting or affected by the heart, and what machines and what we can't do. If you have somebody who has significant heart failure, severe, almost end stage heart failure, where the heart's barely moving and their kidneys are failing and they need dialysis, we don't offer dialysis to those patients because pulling the blood out of the heart to get in the dialyzer, the heart just shuts down and the blood pressure plummets, and we have to stop dialysis. So, it kind of really patient specific for that. What happens if an artificial valve slips out of its place? Traditional valves are put in, they're sewed into place, they don't slip out. The catheter valves have little grips on the side of them that attach, but they can move. I've seen it a couple of times, and it's an oh crap moment, and you try and retrieve it and put a new valve in. And they can become surgical emergencies. In what situation would you use open heart surgery to replace a valve and not through a catheter? It depends on who you talk to. The cardiac surgeons don't want to do the valves because they're done by cardiologists and they don't get paid for doing the valve surgery. But typically, when you're going to do an open valve, you're also going to do bypass surgery at the same time. Anybody undergoing bypass or undergoing valve surgery has to have a cardiac cath done to see, do they have coronary artery disease and do they need bypass surgery? Because they would do that at the same time. What's the main difference in using a heart from a deceased person or a mechanical pump to treat heart failure in terms of how the body functions post-surgery? So functioning post-surgery, there's really not a difference. Realize, less than 4,000 heart transplants are done a year nationwide. And that's simply because we don't have a wide availability of donor hearts. In terms of the pump, the newest generation that's out on the market was just approved for long-term use in October of 2018. So we're just at 6 years almost that it's been on the market. So we need long-term studies to evaluate, the comparison between transplant versus heart pump. They did publish data at the 2-year mark that showed an LVAD or the heart pump was almost as effective as transplant at the 2-year mark, but we need to see 5-year, 10-year, 15-year data. Part of it is also the age at which the patient's being implanted. For transplant, general age cutoff is 70. Anything above that, we don't do a heart transplant on. There's a lot of barriers to transplant with BMI, tobacco use, substance use, kidney function. So we may go to LVAD because of those issues. Somebody's been reading up here because they're asking how fractional flow reserve and intravascular coronary ultrasound enhance the accuracy of coronary angiography. That is a great question. It's an underutilized technology. So when we do a catheterization, you saw those pictures, it's an estimation in the cardiologist's eye of what percentage blockage it is. And we tend not to put a stent in until we're greater than 80% blockage. And there's something called intravascular ultrasound where we can actually do an ultrasound inside the coronary arteries and do this FFR, fractional flow reserve. And if it's above or below a certain cutoff, indicates if they should receive a stent or not. Unfortunately, not enough cardiologists do it. And sometimes we place stents when we shouldn't have, or other times, there's a visual misinterpretation of how severe the blockage is, and we never did those measurements. And the patient really would have benefited from a stent. So I'm really surprised the insurance industry has not made it mandatory that we do intravascular ultrasound and FFR on every catheterization to justify them paying for a stent. When you get an aortic valve replacement, are there different types of valves? The hospitals use different ones. Generally, there's a few on the market. There's only so many companies that are going to make this, just because the tens of millions of dollars that go into creating these things. Those companies have to be able to make their money back. So if there's too many companies on the market, they're just not going to have enough volume. We have mechanical valves that are literally just metal valves, open and close. Patients need to be on an anticoagulant with that. And then you have what we call bioprosthetic or pig valves, that they don't have to be on blood thinners. They're tissue valves, but the tissue can wear out over time. Performing research on blood on a microscopic level and how they change based on supplements, energy drinks. How does the heart relate to hemoglobin levels, oxygen through blood, and how does that change fresh blood that is accessed through the heart? So there's, more and more research coming out on these energy drinks. I've got, a 15, 17-year-old and a 20-year-old at home who love to drink these monster drinks and Red Bull and all of that stuff. And there's more information coming out about the chemicals in that and then the cardiac toxic effects that they have. We need to see more. I keep trying to get them to quit drinking them. I refuse to buy them for them because of the known issues with the heart. Plus, that much caffeine is a direct stimulant to the heart and causes the heart to beat faster, work harder. So they're not good. In terms of the hemoglobin on the heart, so anemia or low hemoglobin can actually impact heart function. I've got a lady right now I was actually supposed to see in the office yesterday, and she ended up admitted the night prior to the emergency room with significant anemia, and she gets chest pain or angina when her hemoglobin's low because the heart has to work harder. So she had to come in and get blood transfusions, and as soon as we give her blood, the chest pain goes away. So there is a known association of anemia affecting cardiac performance. We don't get as much blood. Your hemoglobin is the part of the red blood cell that delivers or carries oxygen. So a normal hemoglobin, you're looking at 12 to 15, depending on the lab. You're looking, their reference range. So if your hemoglobin like hers was 6.8, we're half the oxygen carrying capacity. So she's going to feel fatigued, short of breath. The heart's going to have to work harder. Which cardiac diseases can easily be mistaken if you do not take the specific measures? Oh, a lot of things. So coronary artery disease, you get this what we call mid-sternal chest pain right over your breastbone or your sternum. Your esophagus sits right there. So a lot of times patients will have this burning pain and they think it's acid reflux or heartburn. Is really, cardiac function. We see in heart failure, especially in our younger population, in patients in their 20s and 30s, they'll have shortness of breath when they lay down at night. They get a cough, their breathing's worse. They go to a walk-in clinic. They're told, oh, you have bronchitis. They're given an antibiotic. Weeks go by, they're no better. They go back a different antibiotic. Third month happens, they go to their doctor, they end up in the emergency room, and lo and behold, they've had heart failure, because we don't think of heart failure in the younger population. So that's probably, some of the biggest things that we see when we're not thinking the heart, and it truly is the heart, but we've missed it because of other things. You're thinking of career in healthcare, it's zebras and horses. Horses are much more common. Zebras are out there though, but you don't want to miss the horse looking for the zebra and vice versa. So this is just where experience and training comes into play, and realize you can't know everything, and the clinician who thinks they know it all is more of a harm to the patient than the clinician who says, I don't know, but let me go look it up. So if you take anything away in your future, is realize that and be that clinician who says, I don't know, let me go look it up, instead of thinking I know it all and we make mistakes. Where can Dr. Lang's book be purchased? I don't know if you're talking about the book I had on diuretics. That's just a joke book that I have used for a long time on diuretics with IP freely, because sometimes talking about heart failure can become monotonous and boring. I wish I had a book to be able to sell. How long does it take to recover after having open heart surgery? It varies on the patient. And, the younger the patient, the healthier they are going into surgery, the faster they recover. If you're 80 years old and can't do a lot of physical activity, it's going to take quite a while to recover. What happens if an artificial valve accidentally falls into the chamber? It's a surgical emergency. If you can make it to surgery, a lot of times you just go into what we call flash pulmonary edema, where the lungs just fill up and you go into respiratory failure before we may even get you to the operating room. Why are cardiac caths done more through the groin instead of the wrist? So the wrist catheterization is a relatively new thing. It's only been around about 15 years. The reason being is that the femoral artery in your groin is a much larger vessel, and then the radial artery in your wrist. So it was traditionally done. It was easy access. Problem with that is that there's increased risk of bleeding after the cath. Patient has to lay there with their legs straight for 4 hours, whereas the wrist, you can hold direct pressure. So we're seeing more and more radial approaches done. But you still have a generation of cardiologists doing procedures that were never trained in the radial approach. Excuse me, through the wrist, it still go through the groin. How long do heart operations normally take place, like placing a stent versus an LVAD? A stent, in all honesty, we can be in and out in 10, 15 minutes placing a stent. If it's, you find it quickly, you know where to go, there's no issues with it. And LVAD, you're looking at a minimum of 6 hours in the operating room. I've been in cases where we were in surgery for 10 plus hours, went to the intensive care unit from the operating room. I was home for an hour and a half and got called back, and we were another 8 hours in the operating room. On the same patient. So those are rare that they go that long. Typically, you're looking, for an LVAD implant, 6 to 8 hours. How can anxiety affect the heart? So anxiety can increase your stress hormones, and that places an increased workload on the heart. So if you remember the medications we were talking about with the beta blockers and how they help suppress the stress hormones, norepinephrine, vasopressin. So those are our stress hormones. They're stimulated by anxiety, and it can cause the heart to beat faster and increase the workload of the heart. Can losing weight quickly lead to heart failure? No. Uh, we actually encourage weight loss in our patients. So when we look at heart transplants, you have to have a BMI or body mass index of under 37 generally. Some places go to 35. Anything higher than that, they won't do a transplant. So we've had several patients over the years where their BMI was too high for transplant. We put an LVAD in them. They were too high risk for bariatric surgery without a transplant or LVAD. So we had put the LVAD in them and then let them recover from that surgery. A few months later, they underwent bariatric surgery to lose weight to then undergo transplant.
Hey, Craig, can I interject my own question here? So, too rapid a weight loss, not a factor. However, what about people who lose weight through extreme dehydration?
So you're going to get to a certain point where there's no further weight loss with dehydration. Your kidneys will shut down. So it's where is the weight coming out? And we see this in heart failure with weight gain. So every liter of water weighs 2.2 pounds. Okay. We tell heart failure patients if you gain 3 pounds or more in a day to call us because we know that's fluid. In order to gain 3 pounds of flesh weight in a day, you would have to consume over 17,000 calories in 24 hours. And unless you're an ultra marathoner, you're not going to be consuming that many calories. So when we see the rapid weight loss like that, we give aggressive diuretics, and we can see. I've had patients I've pulled 8-10 pounds off in a day just in fluid. Okay. So if it's fluid weight you're losing from dehydration, eventually there's no more fluid to come out, and the kidneys are going to shut down. The flesh weight that we lose is not going to come down that quickly. So we tend not to see the same issues as you would with rapid weight loss from fluid. That answer it?
Yep. Thank you.
Yep. For someone with a long-term heart murmur since childhood, now over 50, can they expect the valve to eventually need to be replaced? Part of it depends on how long you're going to live. And the reason I say that, patients ask all the time, how long do you think I'm going to live? Now, we do have risk calculators in the heart failure world that can give a 1, 2, and 5 year risk predictor for dying. But it's not 100%. But I always tell patients, I could tell you you're going to live another 30 years and you leave my office and pull out on the highway here and a tractor trailer hits you and die in an accident. Well, my prediction is off. So when we look at how long you're going to live, realize that the average life expectancy in the United States is 71 years, on combining male and female. Females live a little bit longer because guys tend to do stupider stuff than females do, which lowers the life expectancy. And with COVID since 2020, there's actually been a drop even further in average life expectancy, getting closer to 70 years. So if you're already over the age of 50 and you have this, you have to take that into mind of what the average life expectancy is. Now, we know because the valve this tissue has been flapping every heartbeat since before you were born, there is a higher chance of that valve needing to be replaced. We grade valve dysfunction on either none, trace, mild, moderate, and severe, and we don't operate until it's severe and you're symptomatic. So it would, a murmur, simply the audible sound of a valve not opening and closing properly. So it could be trace and mild and stay that way your whole life. Other patients can have no problems and all of a sudden severe shows up out of nowhere. What would you recommend for high school students to do from now so they can prepare for a career in this field? So this is a great question because I have a 17-year-old that wants to go to medical school. And he and I have had this discussion a million times. First thing to do is have a balance in your life starting now. Okay. Medical school is not going to look at your high school transcripts. Okay. Second thing is you don't have to pick a science major to go to medical school. The reason I did not go to medical school and I went to NP school was I goofed off as an undergrad, to be honest with you. I was a music major. I just needed to graduate to teach. And I did look at going to medical school, but I was getting married at the time and chose this route. I would say for high school now is try and get as much experience as you can. I know some of the high schools have pathways. Where my son is at in high school, they actually have a healthcare pathway, and that's what he's in. And in last spring, he had anatomy and physiology, and he's got a healthcare class this semester as a high school student. So it opens up opportunities and awareness and see the various things that are out there. Take science classes. Now, to get into medical school, you have to generally have 2 semesters of inorganic chemistry, 2 semesters of organic chemistry, and 1 or 2 semesters of physics in college. Do any of those classes really help you be a better doctor? No, not at all. Okay, part of it is weeding out classes. Okay, if you can't handle those classes in college, the likelihood of handling medical school is low. Okay, so take the science classes and see, can I handle this? And I remember being in high school, I took physics, and at the time I wanted to go to the Naval Academy, and I struggled with high school physics. And I said, well, if I can't do high school physics, there's no way I'm going to survive the Naval Academy. So that dream went away quickly. Again, volunteer, try and get exposure to different things, and I would say just don't focus on the med school route. And I've had this discussion with my son of explore everything in healthcare. Had I known what a perfusionist is, they're the ones who operate the heart-lung bypass machines for open heart surgery. I quite possibly would have done that. I find that work fascinating. I never knew what that was until after I was already, as a nurse. There's radiology fields, there's therapy, physical therapy, occupational therapy, there's medicine, there's nursing, speech pathology, audiology. I mean, there's a million things. So I say in high school, try and soak up as much as you can of all the different fields. If you can get time, seeing procedures, if you can volunteer and see that if the sight of blood makes you pass out, medicine may not be the best thing, but there's still jobs in the medical field where you don't have to deal with blood. So, and that can change over time, but just look for those opportunities is the best chance. It's hard when you're in high school for people to take you seriously that you want to do this, but it takes dedication and time for any healthcare career. So I say go for it.
And if I can add 2 things to that. Number 1 is don't let anyone tell you what you can't do. And number 2 is, with all due respect to parents, don't let your folks tell you what you should do. I want you to be a doctor. You need to choose your path because it is a path. It is a journey. As you've heard Craig talking about, it's a big commitment. So make sure you're all in because you want to be all in. Last medical question, Craig.
And I think we already answered this one. And what situation?
Okay, I thought we did too.
Yeah.
All righty. Well, Craig, fantastic presentation, and thank you for sticking with that exhaustive Q&A. Next week,
I love all the questions. It's terrific.
Yeah, great. Next week we have Connie. Oh boy, Connie, I don't know how to say your last name. Well, anyway, we have Connie who's going to be talking about health informatics, which is the application of information technology to healthcare to improve the delivery of care and patient health. One of those things that doesn't involve blood. Anyway, everyone, good evening. And the recording will be up at DelawareMinimed.org here in a couple of days. Again, Craig Laing, thank you very much. Good night.
So everybody.